Greetings. Let us learn about dye sprays in GI endoscopy. Couple of dyes are available in the endoscopy unit. One is methylene blue. This is otherwise known as an absorptive dye because it gets absorbed by the cells and stains the cells blue. If you go into the pathology lab, methylene blue is quite often used as a staining technique of GI biopsies. In contrast to methylene blue, indigo carmine does not get absorbed but just highlights the mucosal surface, grooves, etc. Hence, indigo carmine is known as a non-absorptive dye. Between the two, indigo carmine is preferred because it can be washed off easily so that you can look at a normal lining without the interference from an absorptive dye that happens with methylene blue application. So between the two, I prefer indigo carmine. And what happens when you spray dye? As you can see here, this is colon. Looks pretty much normal, but sometimes subtle lesions, the eye may not pick it up. But when you give spray dye, these subtle lesions that your eye cannot pick it up can be highlighted and made easily recognizable. So you can see 3 subtle flat lesions recognized after dye spray. So when you want to set up a dye spray for a case, you have 2 options. One option is you could set it up in such a way that you could put the dyes into the water canister and the endoscopist presses on the foot pedal to deliver dye through the water jet. So when it comes to that, you take a couple of vials of dye and put it in 250 ml of water, and that gives about 0.03% solution. That is the preferred solution for screening purposes, 0.03% solution. And once the dye solution is set up and ready to go, all that the endoscopist needs to do is press on the foot pedal, and with the water jet mechanism, the dye gets sprayed, and then examine the segment to make sure whether it is normal or has subtle flat lesions, as you can see here. So this is one way to do. There is another way, that is using a dye spray catheter. So here is a dye spray catheter. The tip of the catheter has this metal ring, and it gives a spray, almost like a circular spray, fine mist. And for dye spray catheter also, you need to take maybe 10 or 20 cc saline mixed with the dye, giving a concentration of 0.03% solution. And you give this catheter to the endoscopist. He inserts it through the biopsy channel, and once the catheter comes out of the endoscope, he asks the assistant to press on the syringe plunger to flush the dye, and the dye comes out as a spray. And as it sprays, it highlights the mucosa, and the subtle flat lesions can be easily seen. As you can see, for screening purposes, we use a very dilute dye at a concentration of 0.03%. If you see a subtle lesion and you're not sure and you want to define it further, in terms of whether it is a flat lesion or a depressed lesion, and you want to define it further, then you may want to use a little more concentrated dye, almost like 0.13% solution, and that will give a better definition of the surface architecture of the polyp. So we've learned about dye spray techniques. Some also use a 60 cc syringe and then flush it through the biopsy channel if they want to do a quick job in a small area. So there are different ways of doing dye spray, but it is important to keep in mind two important facts. For screening purposes, a dilute solution, 0.03%. For delineation and definition of a polyp further, a little more concentrated solution, 0.13% solution is preferred. When it comes to dye spray chroma endoscopy, and where can we use this technique? It can be used for surveillance of patients with long-standing inflammatory bowel disease, either ulcerative colitis or Crohn's that has lasted for at least 8 years or longer, patients with Lynch syndrome or hereditary non-polyposis colorectal cancer syndrome, where lesions tend to be very flat and very subtle. This can be used in the colon or in patients with FAP and Lynch, you want to check for duodenal adenomas. It can also be used to delineate flat lesions, especially colon polyps, and you're not sure whether there is a depressed area, or there is an advanced mucosal pathology, then you use a concentrated solution, 0.13% solution. People in the past have spent a lot of time doing research by using dye spray technique in evaluating patients with Barrett's esophagus. For some reason, not many people use this. It has also been used for evaluating gastric pathology. In terms of adverse effects, dye spray, unless there is an allergic reaction to the dye, this can be used routinely without a problem. And one thing you may want to share with the patient is their output. Sometimes the urine can turn green if it gets absorbed. So you want to caution the patients about changing the urine color. That will resolve over a period of hours. And the second problem that one should keep in mind is if the stool can be colored if you put in a lot of dye into the colon and don't suction it out. So we've learned about dye spray, one for screening purposes. Second one is delineation purposes. For screening purposes, 0.03% solution. For delineation purposes, 0.13% solution. And you could either use it with the spray catheter or through the water jet channel or through the biopsy channel, depending upon what works for a particular endoscopist. I hope this is useful. Thank you.